Assalamualaikum. Today we are going to discuss nephrotic syndrome. As we discussed earlier, interpretation of the investigation which help out us the diagnosis of the renal disease. At that lecture we discussed regarding the proteinuria, the selective and non-selective and normal proteinuria. So today we are going to discuss the nephrotic syndrome. So what is nephrotic syndrome? Nephrotic syndrome is a pathognomic of glomerular disease in which increase the permeability of the glomerulus leading to loss of protein into the tubules. Means protein filter from the glomerulus because of the increased permeability. Many causes which can lead to the increase the permeability of the glomerulus, which leak the protein into the tubules where from out of the kidney. So the nephrotic syndrome is a pathognomic of the glomerular disease in which increase the permeability of the glomerulus leading to loss of protein into the tubules. Nephrotic syndrome by definition triad of massive proteinuria, more than 3 gram in 24 hours, more than 3 gram in 24 hours, and hypoalbuminemia less than 2.5 milligram per deciliter or less than 25 gram per liter, and edema. Loss of protein means loss of the osmotic pressure. It leads fluid leak from the interstitium, intravascular to interstitium, which clinically indicate the edema. So the proteinuria more than 3 gram in 24 hours, hypoalbuminemia and edema, and often hypercholesterolemia and dyslipidemia, total cholesterol more than 10 millimole per liter. Why this occur? Because increased hepatic synthesis of the LDL and VLDL and lipoprotein, and defective peripheral lipoprotein lipase activity resulting in increased VLDL, urinary loss of HDL lipiduria. That's indicated in the urine DR oval fat bodies or fatty cast. Okay. What are the causes of nephrotic syndrome? Primary glomerulonephritis, the primary causes, and as well as secondary causes we discussed later. The primary glomerulonephritis, this is the lesion which in the classification of the nephrotic syndrome. Minimal change disease, 80% pediatric cases, बच्चों में जो होता है minimal change disease. Focal segmental glomerulosclerosis, most common in adults. Membranous glomerulonephritis, membranoproliferative glomerulonephritis. These are the lesion of the nephrotic syndrome. Minimal change disease, FSGS, focal segmental glomerulosclerosis, membranous glomerulonephritis, and membranoproliferative glomerulonephritis. Minimal change disease commonly seen in the pediatric cases. In pediatric cases, secondary glomerulonephritis means systemic disease can lead to these lesions. Means secondary causes that's present with these lesions. Okay, the secondary cause is diabetic nephropathy, is also secondary cause of the nephrotic syndrome. Sarcoidosis, autoimmune SLE, Sjogren can lead to the membranous secondary cause of the membranous glomerulonephritis. Infection, syphilis, hepatitis B, and HIV. These also cause membranous glomerulonephritis and as well as FSGS. These are the secondary causes of these lesions. Amyloidosis, multiple myeloma, vasculitis, cancers also lead to the membranous nephropathy, FSGS, membranoproliferative glomerulonephritis. Drugs, gold, penicillamine, captopril, and NSAIDs. Penicillamine, gold can also lead to the membranous nephropathy. These are the secondary causes of these lesions. Okay. What are the common glomerular disease presenting as a nephrotic syndrome in adults? As I defined earlier, these lesions, again in this chart, the minimal change disease, association of the minimal change disease, allergy, atopy, NSAIDs, and Hodgkin disease. As I said earlier, cancers, drugs, and allergen can lead to these lesions. So commonly, minimal change disease associated with allergy, atopy, NSAIDs, Hodgkin diseases. Focal segmental glomerulosclerosis associated with the African Americans, most commonly HIV infections can lead to the focal segmental glomerulonephritis. Heroin and palmitoylate drugs can lead to the focal segmental glomerulosclerosis. So we investigate according to the cause. If HIV infection, we should go for the HIV antibodies. And on the history basis, like heroin or palmitoylate drug history, also indicated the cause of focal segmental glomerulonephritis. Membranous nephropathy associated with idiopathic drugs, gold, penicillamine, idiopathic and drugs like gold, penicillamine, and NSAIDs, infections like hepatitis B, C, malaria, lupus is also present with the membranous nephropathy, lupus nephritis. Malignancy like breast, lung malignancy, gastrointestinal malignancy can also present with the membranous nephropathy. The serological test, again, according to the cause, the primary membranopathy in which anti-LAR antibodies should be positive. The infection, if according again we take the history, which is important, which indicate what the secondary cause could be. Like patient having any jaundice, ascites, patient should go for the serology like hepatitis B surface antigen, anti-hepatitis C virus antibodies, and lupus anti-DNA antibodies. So the membranous glomerulonephritis, MPGN, C4 nephrotic factor, serology, C3 decrease, C4 decrease in the serum. Dense deposit disease, MPGN type 2, and membranoproliferative actually divided into two classes, class 1 and class 2. Class 2 is a dense deposit disease also called, in which also the C3 and C4 complement levels are C3 nephrotic factor and C3 decrease, but C4 is a normal. In class 1, C3 is decreased and C4 is decreased. This is a different which differentiate both classes. In class 1, C3 decrease, C4 decrease. In class 2, C3 decrease, C4 normal. Okay. Again, amyloidosis and diabetic nephropathy is the cause of secondary glomerular disease, nephrotic syndrome. Okay. Again, I repeat, the lesions of the nephrotic syndrome is a minimal change disease, focal segmental glomerulonephritis, membranous nephropathy, and membranoproliferative glomerulonephritis. What the presentation of the nephrotic syndrome? Patient having no previous history of the edema, new onset edema, initially periorbital or peripheral. Could be patient giving history pedal edema on the feet or periorbital edema, especially in the morning time. Later, this edema progressive involved the genitals, ascites, then after anasarca, generalized body swelling. In urine DR, urine is a frothy, and urine DR protein is a positive. Generalized symptoms, patient is a lethargic, fatigue, and reduced appetite because of the gut edema as well. Yeah, the nephrotic syndrome, again, the triad, hypoalbuminemia, hyperlipidemia, massive proteinuria, and peripheral edema. What further possible presentations in the nephrotic syndrome? BP commonly is a normal but can be raised, some cases, 20% cases. can be raised blood pressure. 80% cases with normal blood pressure. Liponychia, breathlessness because of fluid in the lungs, pleural effusion, or fluid overloaded, or nephrotic syndrome can lead to the acute kidney disease or acute kidney injury in which the retention of the fluid kidney is not able to excrete the urine, which leads to the volume overload, can lead to the pulmonary edema and patient present with the breathlessness. DVT, pulmonary embolism, and myocardial infarction, these are the common complications of nephrotic syndrome. Because this is a hypercoagulable state. Why? Because the kidney, the protein urea, the coagulation proteins are lost in the urine, the feedback to the liver, they increase the hepatic synthesis of the coagulation protein. One. Second is a hyperlipidemia, can excrete atherogenesis, which leads to the arterial thrombosis. Other platelet increase platelet aggregation, volume contraction, because as I already said, decrease intravascular volume can lead to the hemoconcentration. And immobility is also, these are the causes of hypercoagulable state in these patients. Eruptive xanthomas and xanthomata and xanthosomata. These are the hypercholestemic signs. What are the different diagnoses of the edema? The congestive cardiac failure and liver diseases. These are the differential of nephrotic syndrome. It means in history, if patient is presenting with edema or ascites, we should take the history, patient having any cardiac failure history, patient having a liver disease already. If patient having a no congestive heart failure, no liver disease, it means patient might be, the possibility is suffering from nephrotic syndrome, means renal related problems. In congestive cardiac failure, raised AVP clinically, pulmonary edema, mild proteinuria. As I say, the nephrotic syndrome, the proteinuria more than 3 gram in 24 hours, but in congestive cardiac failure, it could be less than 1 gram in 24 hours. Liver disease, hypoalbuminemia, ascites and edema, because the protein albumin synthesis problem, the albumin synthesis in the liver. If liver disease is albumin can't synthesis, the body having decreased concentration of the albumin, also the same mechanism, decreased chloride osmotic pressure, so the fluid intravascular shift to the interstitium can produce with the edema, the mechanism is the same. But in urine also the protein concentration is a decrease, not more than 3 gram in 24 hours. Investigation. What investigation we do in the nephrotic syndrome? The urine dipstick which shows protein as well RBCs. Some cases can be present with RBCs. Fatty cast, urine microscopy, and urea, creatinine, serum electrolytes. Most of the patients with the nephrotic syndrome, the renal functions are normal, but later on, most of the patients with normal renal function could be abnormal. Some patients blood test UUL1 once plus renal screen, immunoglobulins, electrophoresis, complement level, antibodies, ANA, NCA, and anti-double strand DNA, anti-GBM. According to the cause, we proceed the investigations. Renal ultrasound, which shows renal size, parenchymal changes, any obstruction. Finally, if we should go for the renal biopsy, the renal lesion, which I already explained, the minimal chain disease, focal segmental glomerulonephritis, membranous nephropathy, membranoperipheral glomerulonephritis, these lesions Diagnosis on renal biopsy. So the renal biopsy is the gold standard test in the glomerulonephritis or nephrotic syndrome. But in children, we should not go further directly for this test. We should trial of steroids, as I earlier said, minimal change disease 80% present in the pediatric patients and most commonly responds to the steroids. So, what the management? Conservative management, monitor urea, creatinine, electrolytes, blood pressure, fluid balance, weight, salt, and fluid restriction. If patient present with the edema, we restrict the fluid, we restrict the salt, then after we treat according to the cause or underlying cause. For the medical conservative treatment, diuretics, if patient is in the volume overload, we give the diuretics and ACE inhibitor ARBs, which help us for the preventive for the proteinuria. Corticosteroid and immunosuppression is the treatment, and if patient is in renal failure which is not responding to the medical therapy, so we should go for the dialysis, hemodialysis. And anticoagulation, as I say, the nephrotic syndrome is a hypercoagulable state. The anticoagulation is also indication in the conservative management. So the patient is not responding to the medical treatment, then renal failure, and we should go for then hemodialysis. If patient develop CKD, chronic kidney disease secondary to nephrotic syndrome, and patient is dialysis dependent, then the choice of treatment is renal transplantation. Okay, what are the uh, uh, what are the how would we differentiate between the nephrotic syndrome and nephritic syndrome? The nephrotic syndrome onset insidious, and nephrotic syndrome is abrupt. Edema commonly present in the nephrotic syndrome, but present can be present in the nephrotic, but not like a nephrotic syndrome. Blood pressure usually normal in the nephrotic syndrome, raised in nephrotic syndrome. JVP normal or low in the nephrotic syndrome, but raised in the nephrotic syndrome. Proteinuria positive 4 times, means heavy proteinuria in the nephrotic syndrome. Hematuria may or may not be in the nephrotic syndrome, but positive in the nephrotic syndrome. Cast absent in the nephrotic syndrome, but positive in the nephrotic syndrome. Serum albumin is low in the nephrotic syndrome, but can be normal or slightly reduced in the nephrotic syndrome. Okay, thank you.